Test. Should we get started? Okay. All right, we're going to get started. Thank you, everyone, for joining us. Today we'll be talking about multimodality imaging and cardiovascular prevention. I have no disclosures relevant to this talk. So the objectives of this talk, I thought that we can describe the different imaging modalities that we can utilize. The focus, obviously, here is going to be on CT, although I'm going to mention other imaging modalities that we're going to utilize. We're going to explain some imaging-based biomarkers that can guide therapeutic interventions, specifically in personalized cardiovascular prevention. And I'll allude to some of the recent research on predictive value of multimodality. How can we combine them? How do we understand this in the context of polygenetic risk scores and biomarkers? And how can we contextualize this to understand personalized cardiovascular prevention? So one thing that, during my medical school training and cardiology training and internal medicine training, it's always whenever we talk about cardiovascular disease, we think of simple terms. We think of all cardiovascular disease as one, right? When we talk about atherosclerosis, we think of one. And so I call cardiology as a field as lumpers. And this is very different from oncology. So if you go across the street in Neal Cancer Center or you go to MD Anderson, you'll find that people do very different approach, right? In oncology, people do to the cell level. They look at molecular phenotyping, and then they design therapies that can really target some of these molecular pathways. So oncology is splitters, cardiology is lumpers, and how can we move from lumpers to splitters? Because really that's how we move from a generalized kind of approach to a precision or personalized approach. The other thing that we don't do as well as cardiologists is we really think of disease as stages without overlap. So we've always been taught, if you open any guidelines right now in ACC, AHA, you'll find that we talk about stages of disease, stage A, B, C, D, without significant overlap. And we think about primordial prevention, primary prevention, secondary prevention, and tertiary prevention. But we would argue that basically risk is a continuum, right? And it's dynamic to a certain degree as well. So there is a significant overlap between primary prevention groups and secondary prevention group, and even tertiary prevention groups. And just having a group that has primary prevention does not mean everybody in the primary prevention group is lower risk compared with the secondary or even tertiary prevention. So we argue that basically there needs to be a universal risk prediction model, so to speak, that accounts for the dynamic nature of risk, but also accounts for the overlapping risk. So why do we need personalized intervention? So cardiovascular prevention has been a dead field for a long time because basically for decades that's what we had. We had aspirin and statin, and that's all you have. That's all you get. And now this is the paradigm right now, right? So we have PCSK9 inhibitors, we have ezetimibe, we have Vascepa, which basically targets triglycerides. We also are moving towards inflammation. You've heard from Dr. Libby the other day about targeting inflammation with IL-1 beta antagonist, with IL-6 antagonists. But we also have anticoagulants that we can utilize in prevention. We can use now GLP and GIP antagonists, GLP-1 receptor agonists and GIP agonists as well. And we can understand SGLT2 in patients who are at least have type 2 diabetes. But we also have other new targets, right? So there are other cytokine inhibitors and agonists that that are in development. We have a lot of things that are ongoing to target the interstitium, the cardiomyocyte. So this field is always going to get complicated. And when I see patients in clinic right now, oftentimes it's difficult to decide which patient comes first. What do I start with? Yeah, of course, statin comes as the first line, but then afterwards, what do you use afterwards, right? So that's where there is a need for personalized intervention. Not only that, it turns out that some of the therapies that we utilize in cardiovascular prevention these days have a specific targeted effect on some imaging-based biomarkers. So if you were to look at SGLT2 inhibitors, you look at GLP-1 receptor agonists, you look at statins, and this is just an example, it does have an impact on epicardial fat, which we know is a probable mediator of cardiovascular risk, specifically myocardial infarction and stroke risk in general. So there is that is also fueling the impact of understanding imaging-based biomarkers to understand and reduce cardiovascular risk. So let's review, and most of this talk is going to be on atherosclerosis because probably this is the most studied with respect to biomarkers and prevention as well, but some of these applications and some of these concepts will apply to heart failure, atrial fibrillation, and other cardiovascular events. So let's review the pathophysiology a little bit. As you know, atherosclerosis starts initially with intimal thickening, and then it moves either to nodular calcification or thick cap. And then that thick cap over time that can become thin cap with the collection of atherogenic lipids and recruitment of inflammatory cells, and then that leads to fibroatheroma, which is basically either thin cap, thick cap, fibrocalcific, or ruptured. This is where acute coronary syndrome is. And then you also have this ulceration, plaque ulceration, which can move from stable to plaque ulceration and leads to type 1 MI as a plaque erosion. So across the spectrum, and this is obviously a simplification, but you've seen this figure multiple times, across the spectrum of atherosclerosis, we do see lipid-rich buildup of atherosclerosis here, but we do see calcification that happens relatively early on. And basically part of healing process is calcification of atherosclerosis. So if we were to target atherosclerosis calcification phenotyping or understanding in the beginning, then we can probably identify patients who are at risk for cardiovascular disease in the future. But also, the field is moving now. We started from here in the 70s and 80s. We started to think about myocardial infarction and started to think about thrombus now and rupture and vulnerability of plaque using IVUS and OCT and then calcification. And now the field is moving towards CTA understanding of atherosclerosis, where we can identify patients even earlier here. And then I would argue also we're starting to understand patients who may have a normal or seemingly normal vessels on CT that may have risk for the future with using pericoronary adipose tissue understanding and characterization. So this is one of the dogmas in cardiovascular medicine is basically as atherosclerosis builds, it builds externally, right? So it starts with a disproportionate increase in vascular size or the vascular vessel wall to the external, so external remodeling or a positive remodeling, and then only when you get to the point where the plaque becomes active, inflammatorily active, and hemorrhage, intraplaque hemorrhage, then starts impinging on the lumen. And that's really where it's a late stage. So you want to pick up patients here in this A, B, C, D, E, F stages before they rupture and before it becomes an active plaque, so to speak. If you were to review patients, and this is a nice, interesting figure that shows if you were to review patients who had, at the time of MI, they had some, semi-obstructive disease, but then if you were to go back in time and look at them, the vast majority of them actually, approximately 6 to 12 months prior, if you were to image them serially, they don't have obstructive disease. So about 2/3, between half and 2/3 of MIs actually happen in non-obstructive disease, which really is an important concept because when you do functional testing to risk stratify patients, you're only picking up the rate limiting or the flow limiting lesions that have an impact on ischemia. But you're missing between half and 2/3 of patients who may have significant disease, but they're not picked up by stress testing and functional testing. So going back to the kind of the spectrum of atherosclerosis, you need we have now imaging modalities that can really capture the disease from beginning all the way to the end, right? So of course we have cardiac MR that can identify LV remodeling. This is at the end stage when you have ischemic cardiomyopathy. You can identify scar burden. You can have clinical symptoms which can usually start before then. We have ECG abnormalities that can pick up patients in the late stage, but obviously there is emerging field of ECG, AI, that can really pick up patients around this area where they have maybe normal or semi-normal vessels. You have systolic and diastolic dysfunction. And of course, this is an oversimplification because you have some overlapping findings, but just conceptually, you can identify disease across the stages with different imaging modalities. And this is basically where molecular imaging comes in handy, which is still in research purposes right now and research applications. But we also have functional imaging and anatomic imaging, which are really moving in the front and center. So going back to the anatomic atherosclerosis phenotyping, and this is one of the first initial kind of explanation, description of identification of vascular calcification non-invasively. This is the work by Dr. Agatston. And you can see initially he used a technology that is no longer used. It's called electron beam CT to quantify the amount of calcification. This is from his original paper in the 1990, where you can see specks of calcification in the LAD, and then probably a little bit of in the left main as well. And then, as the technology of CT evolved, now we can quantify the same amount using multi-detector CT, which is the technology that we have right now. And basically, they correlate very well if you were to do the same test on EBCT and multi-detector CT. So how do we do Agatston score? And so basically what we do is we quantify the number of voxels that have a 130 Hounsfield unit or higher. And then we multiply that area or the volume, so to speak, by the peak Hounsfield unit factor. So that peak Hounsfield unit factor is a correction factor. So it takes into account, if you have a few voxels that have high peak, then they drive the Agatston score in a much higher degree compared with a low density calcification. Now this is a little bit of problematic, although most of the literature right now is focused on Agatston score, but now we're realizing that heavy calcifications are actually stable disease, as they should, because they're, it took longer for them to develop, so they're not usually the problem. What it represents is the problem, which is then, the reflection of non-calcified disease. Because Agatston score is heavily weighed by the fact that you take the peak intensity of each plaque, then it does not capture the entirety of the cardiovascular risk within this aspect, because it turns out that 1K plaque, for example, the heavy density plaque, may be less risky compared with the less dense calcifications. And we know this because we know in CTA, for example, from the CTA literature, the smaller the calcification, we call them spotty calcifications, are actually part of the high risk plaque characterization. So you can see basically here in this area, we're measuring the area in millimeters square of this plaque, which is more than 130. And then we have a peak Hounsfield unit of 450. So we use 4 as the correction factor or the attenuation weighting factor. And then we multiply the 2, and then we add up all the plaques, and then it gives you a whole heart Agatston score. And as you know, this is basically has been shown multiple times by Dr. Nasser and others. Basically, it is probably the most predictive imaging biomarker that we have non-invasively to characterize future cardiovascular risk in large cohorts that has been, diverse racially, diverse geographically. Anywhere you look at this, you see that there is a good prediction of cardiovascular disease. And it's probably even more predictive when you look, and prediction is a complex story, but in general, it's more discriminant of risk of MACE, major adverse cardiovascular events, as compared with any of the clinical risk scores or clinical risk factors, including Framingham and others. Whether you add to them some risk-enhancing factors, including C-reactive protein, family history, ankle brachial index, you name it. Not only that, if you were to take a look into risk prediction by clinical risk factors and risk prediction by calcium score actually reclassifies significant amount of risk. So in this cohort of about 50,000 patients, we looked into pulled cohort equation risk as determined here on the x-axis, and the percentage of patients within each pulled cohort equation predicted risk by calcium score. So you can see even in those who have predicted risk of less than 5%, very low risk predicted by 10-year risk by the pulled cohort equation, a significant portion of them have significant amount of calcium. About 8% of them have calcium more than 100, and about 2/3 or so, 1/3 have about calcium of more than 0. The flip side is also true. If you do have a high predicted cardiovascular risk by pulled cohort equation, 7.5 and above, a significant portion of them, about a quarter, have no calcification, and about a half have less than 100 calcification. So there's some discordance between atherophenotyping risk versus a probabilistic risk score risk by the ongoing equations. Not only that, I think there is actually some evidence to suggest that the amount of calcifications that you identify on calcium score is predictive of a benefit from therapy. So this is a retrospective study, but looking at statin versus non-statin therapy in patients who have calcium score of 0, following patients up for major adverse cardiovascular events. And if you see calcium score of 0 here, there is no difference between statin versus no statin with respect to MACE, while as calcium score goes up, specifically here in calcium score more than 100, where you see there is significant benefit or association between statin initiation and MACE events. Which kind of makes sense, because if you think about it, the number needed to treat if you have a calcium score of 0, then because of the risk of events is very small, number needed to treat would be very, very large. So you don't see much of benefit. But even the relative risk here seems to be also modified. Not only that, when you present data of calcium score to populations, like we do here in Methodist, for example, and do this at large scale, what you do find is that people, physicians, providers, clinicians, they would prescribe statins as according to this calcium score. So for example here, this is calcium score presented to about 50,000 patients, and you can see that as calcium score goes up, the rate of initiation of statin, any statin goes up, the rate of initiation to high intensity statin goes up, and as a result you see a significant reduction, a graded risk reduction in terms of LDL over 1 year. So you can see that if you have a calcium score of 400 and above, then you do have about 16 milligram per deciliter. This is population mean of LDL reduction over 1 year. So this is dramatic reduction in LDL. It may not seem as much, but when you talk about big, large population reducing 16 milligram of deciliter of LDL cholesterol, that's a huge and translates to huge reductions in cardiovascular risk. Aspirin is also the same story. It sounds like as calcium goes up, the risk-benefit ratios goes in terms of number needed to treat to benefit from aspirin. Again, retrospective study, but it looks like as the risk goes up with calcium, the risk-benefit ratio tips towards benefit in terms of reducing MACE events in these patients. So calcium score is also helpful to guide aspirin therapy. Some of the newer concepts, or maybe not very new, but kind of things that are the weaknesses of an Agatston or a whole heart Agatston score. Whole heart Agatston score, which is the calcium score we utilize today, is a simplification of the burden of atherosclerosis. But you can see these two patients have similar Agatston score, but they have very different kind of characterization of calcification. One is heavy in LAD, and the other one is diffuse and looks like in different areas and different vessels. And here the lesion types are small and less calcified, while here is heavily calcified, that's focal and large. So it turns out that there are some characteristics of calcifications that may be even more predictive and associated with the risk of cardiovascular disease. So you can see calcium area turns out to be is predictive of cardiovascular disease in a linear fashion. Calcium density, as calcium density goes up, the risk goes down, as we talked about earlier. Heterogeneity within the Agatston score is also going up with the number of vessels that are involved. Risk prediction also goes, kind of tracks with the number of vessels across the board of calcium score and overall calcium score, and also diffuse versus concentrated. So there are some additional features from calcifications that we can identify and combine to understand the risk a little better. Also, non-coronary calcifications also play a big role in prediction. So you can see here this patient has all sorts of different calcifications, including thoracic aortic calcification, mitral annular calcification, aortic valve, annular calcification of the aorta, and then you also have an RCA coronary calcium score. And then you can see that across the board, all these extra cardiac or extra coronary calcifications also helped with risk prediction and kind of stratifying patients beyond calcium score. One issue that I found really interesting here, with the technology that we do have today, it's called spectral technology or dual energy, multi-energy technology with CT, there is a way that we can identify the type of calcification. Now we call them calcifications because that's what we're trained on, but it turns out that some of these so-called calcifications are not actually calcifications, but they're really uric acid deposits. So this is a nice study that was published a few years ago where they used Siemens technology for dual energy to use material decomposition model, which is actually available on the scanner to understand, and this is widely used to characterize renal stones. And in these patients that they took who have gout, you can see some of these in green, some of these so-called calcifications actually are not calcification, but they're uric acid deposits. So not all calcifications are atherosclerosis. Some of them are uric acid. And maybe there is more beyond that we haven't looked into. And this was actually also proven by cadaver analysis and looking at autopsy results and so on and so forth. Emerging, and I'm not going to talk too much about this today, but emerging technologies allow us to measure coronary calcifications and create a coronary artery calcium score from a non-gated CT. This is, there are multiple papers now, but you can see that actually the association between Agatston score by non-gated CT compared with the calcium score CT, they correlate very well. And also, if you look, not surprisingly, if you look at the future risk of death, myocardial infarction, stroke, all-cause mortality differs by the amount of calcifications that you can do. And you can now do this with deep learning, so you don't have to measure things manually. Now, the concept I mentioned earlier, that the concept of primary prevention and secondary prevention, tertiary prevention is becoming a little bit more blurry because what we used to call as primary prevention and calcium score now overlaps with patients who have secondary prevention or within the secondary prevention cohort. This is one of a few papers that are available in this, but it shows you that if you have calcium score, which is more than 300, the risk of MACE, however you look at it, whether it's myocardial infarction, all-cause mortality, or composite of MACE, is equivalent to patients who have prior ASCVD on CTA. So that shows you that once you reach a level of 300, maybe 250, depending on which study you look at, there is actually, that risk becomes extremely high, and that becomes equivalent to thinking about patients who have prior ASCVD. Now, we looked across the spectrum of disease, but this is another schema that show you a little bit more earlier identification of disease. So you can see that CT plays a big role in identification of the disease spectrum across atherosclerosis, the continuum. So, there is some molecular phenotyping that we still don't understand, we don't use clinically, at least in coronary space, but there is actually things that are moving to the clinical space, including perivascular fat attenuation, which turns out to be a marker of inflammation, and also I'll show you some data around that. Also quantitative burden of atherosclerosis using CTA, identification of atherosclerosis plaque phenotypic features based on CTA, including microcalcifications and other high-risk plaque features, and then also computational fluid dynamics, which is known as FFRCT. So if you were to look at the how does CTA, and this is a little bit of an older study because it's a meta-analysis that looked at 2 decades of studies. Basically, how good is CTA at measuring plaque volume compared with IVUS, which is the invasive gold standard? And you can see that it actually characterizes it very well. You can see that there is, whether it's manual plaque volume or automated plaque volume, when you're doing it on IVUS or CTA, you see actually a very, very equivalent amount of plaque characterization. And you can see that this meta-ROC curve shows you a very high area under the curve to identify a significant atherosclerosis. Now, when we look at the plaque, if you do zoom into the plaque, now we can find there is necrotic core in high-risk features, in high-risk plaques. So you can see thin cap fibrous tissue, and you can find that there is microcalcifications which are indicative of active plaque deposition in atherosclerosis, active atherosclerosis. And it turns out that these high-risk plaque features, there's a longer list, but when we think about high-risk plaque features, we think about necrotic core, TICFA, which is thin cap fibroadipose tissue, and then spotty calcifications and remodeling. And we can actually, interestingly, we can identify a lot of these on CT. So you can see this is the non-calcified plaque versus calcified plaque, which we talked about, and there's also a mixed plaque, and this is the traditional way of analyzing plaque. But there's actually a more kind of more granular understanding of CT attenuation of the plaque. So here, for example, if we have a homogeneous plaque versus a heterogeneous plaque, which indicates a hemorrhage inside, and then you have napkin ring sign, which includes a necrotic core as well, which we can identify on CT, and we identify this on a daily basis in our CT lab. So this is another schema looking at the 4 probably most common, most studied features on CT. that we can identify today on CTAs. And you can see there's positive remodeling. The other one is low attenuation. So if you have a plaque that has less than 30 Hounsfield units, if you have microcalcifications or spotty calcifications, and if you have napkin ring sign, which is basically this is the lumen, and you have kind of thin rim of hyperattenuated kind of area, and then you have a dark area that is representative of necrotic core. And these have been shown, these high-risk plaque features have been shown in multiple studies, this is one of them, to be predictive of future risk of myocardial infarction, independently of stenosis, independently of calcification, independently of the amount of atherosclerosis identified as percent atheroma volume. So going back to this, we talked a little bit about this area, but now we're going to move a little bit more towards BNC. And the CT actually has multiple applications beyond atheroma identification. So this is another schema showing you that we can, beyond plaque assessment, which we talked about, there is traditional assessment, which we also talked about, stenosis percentage and calcium score, and then fluid hemodynamics, understanding FFRCT. There's some molecular phenotyping like we spoke about, and then also there's artificial intelligence applied to understand pericoronary adipose tissue and radiomics of the plaque itself to understand risk in the future. So this is a very interesting kind of field of study that started about a decade ago, probably even earlier. And basically the idea is that CT can provide you information on adipose inflammation. This is a study, one of the studies, probably one of the most famous studies that was done by the Oxford group, where they took patients who have CTs and they took biopsies from them and looked at the fat in terms of with respect to cytokines, and they also did FDG PET on some of these patients. And you can see that CT is basically allowing you, looking just at the attenuation of CT by CT, attenuation of the tissue by CT, it allows you to identify the FDG uptake or inflammation. And you can also, in the same paper, they looked at multiple cytokines and upregulation of local cytokines in the fat tissue. So it turns out that this Hounsfield unit, the lower, the less inflammation, the higher, the more inflammation. And these are, all fat is negative attenuation. So the less negative, the more closer to zero, that's bad. And the more negative, it's pure fat and doesn't have a lot of inflammation. And this approach can also be applied to pericoronary fat. Here it's applied to subcutaneous fat because that's where they took the biopsies from, but you can also apply it to coronary space. And you can understand, for example, there is significant heterogeneity in CT attenuation of the pericoronary adipose tissue and all of the vessels, and you can really understand how this looks with respect to future risk of heart disease. So this is a study, out of many that looked at the future risk of coronary MACE events and all-cause mortality and cardiac mortality, and you can see that low attenuation or less negative attenuation, which is the bad one, it's associated with higher risk in red, compared with more negative attenuation, which is associated with better risk. And now you can see that this actually is independent of high-risk plaque features that I explained to you earlier. So basically, there is added value in patients who have atherosclerosis. There is added value of looking at the FAI, or the fat attenuation index, which is simply just the CT attenuation of the pericoronary adipose tissue, that adds prognostic information to understand risk in the future. This risk is really also associated with statin. So the plaque characteristics, at least, are modifiable, and I'll show you a couple of slides here where I can show you that I can hopefully convince you that these plaque characteristics that we do on CT, these are not static fingerprints, but they're really dynamic, and they change. As they change risk in the future. This is a study that shows you that patients who are not on statin, they have less calcified, more non-calcified atherosclerosis compared with patients who are on statin, where you have less non-calcified and more calcified. So the idea here, which was shown in a couple of studies, that statin moves the plaque from, in addition to regression of plaque a little bit, it moves the plaque from non-calcified to calcified plaque, or stabilizes the plaque. And it could be one of the mechanisms where statin actually helps reduce risk. This is a study of icosapentalyl ethyl, which is basically a Vasipa is what's used in trademark. And you can see this is a randomized trial, blinded, looking at CT at baseline and at 9 months, I think, in in this group, but I think there is another analysis in 18 months. But the concepts are the same. You can see that there is a reduction in low attenuation plaque with Vascepa. You can see a reduction in fibrofatty. You can see a reduction in fibrous. So across the board, with the exception of not significant reduction in calcifications that you do see with as compared with placebo. Same thing can be seen in PCSK9 inhibitors. I'm not going to go in detail in this, but it's the same concept. As you reduce your cholesterol levels, you do see significant impact on plaque characterization. So this is all to convince you that the plaque that we do see is modifiable. Now, just one point of caution. This is a case that I came across in my clinical practice. Basically, not all stenoses that we do see are atherosclerosis. This is an example of a SCAD. This is a patient actually who has spontaneous coronary artery dissection, a woman with fibromuscular dysplasia who had prior multiple SCADs in the LAD, and you can see there is fatty metaplasia that you do see on CT, which was basically scar from her prior LAD SCAD. But now you do see this in the PDA, where you see that there's a significant stenosis, probably about 50%, and you do see that this intramural hematoma, which we can't tell for sure, but this is basically another episode of SCAD in a patient with known SCAD without significant cardiovascular risk factors otherwise. So just keep that in mind, that not all stenosis that we do see on CT is atherosclerosis. So now we're jumping a little bit into how do we do integrated risk assessment and role of AI. There's a lot of studies now that looks into the plaque and the pericoronary adipose tissue and trying to kind of combine these features to predict risk a little bit better. This is a study from the ICONIC study that looked into combination of some of the features that are extracted from the coronary plaque, and you can see vessel volume or plaque volume and the amount of plaque in certain bins of Hounsfield units in attenuation. And it shows that this basically, when you combine them all, you have a better prediction of significant risk in the future compared with looking at either one alone, or you can look at diameter stenosis. So basically, incorporating plaque characteristics into risk prediction can enhance prediction. Not only that, this also has some application in identification of vessels that are implicated in myocardial infarction. So oftentimes when you get a non-STEMI patient, you have some difficulty to a certain degree to identify culprit versus non-culprit lesions. This is a study that looked at patients who have CT around the same time where they had an MI event, a non-STEMI event, and you can see that you are able to tease out the culprit plaque versus non-culprit plaque by just looking at some of the features of pericoronary adipose tissue. So now there is a proposed, now that we moved from a little bit from initial calcium phenotyping into non-calcified plaque, there is a move towards understanding of stages of plaque, and kind of, because one of the problems that we do have in the field is that when you have percent atheromal volume, when you have total plaque volume, you don't have clear cutoffs as to, because we're cardiologists, as simple-minded cardiologists, we think in bins, and we don't have that binning. So now we're going back into the staging system that we're deriving from total plaque volume. But anyways, I think the idea here is to identify it gives you some framework to understand risk with respect to total plaque volume, percent atheromal volume. And you can see, again, going back to the stages, stage 0, 1, 2, 3, and there is some proposals, at least, none of this has been proven yet, but at least some proposals which kind of make sense in terms of understanding designing therapies, prescribing therapies that are designed based on the risk, the underlying risk of the patient. So as you go from stage 0, where you can think about de-escalation, maybe baseline guideline-directed medical therapy, all the way to stage 3, where you can start to put all the big guns, right? PCSK9 inhibitors, colchicine, inclisiran, you can think of pempedoic acid, and so on and so forth. So this is basically, this atheroma phenotyping has been also linked with acute coronary syndrome. So basically, as you move from one feature, patients basically who have high prevalence of high-risk plaque features on CT, they're more likely to have acute coronary syndrome when you look at them in cross-section. And oftentimes, just to realize that when we do atheroma phenotyping, we depend primarily on bins of Hounsfield unit, which has its own problems because Scanners have different impact. Reconstruction filters, reconstruction techniques, heart rate, all that stuff can have impact on the attenuation of the plaque itself, but also the timing of contrast, which has a significant variation between scans, which has impact. So there is some overlap between these when we talk about fibrofatty versus fibrous versus calcified, but to a certain degree, you know, at least the average within each of these is different from the average of the other ones. So as you know, there is, I showed you a couple of these studies where statins and icosapent ethyl impact on atherosclerosis by CT, but there's also some trials on colchicine and DASH diet, physical activity, evolocumab, on basically changing the atherosclerosis shape, looks, volume, phenotype, characteristics on CT, and that has, so to show you that this is basically a modifiable risk factor. With the exception of serial CCTA, you know, when to replace this, I kind of agree with a lot of these staging, and I think, you know, it kind of makes sense. If you have baseline risk that is high, then you tend to increase that intensity of therapies with respect to cost, side effects, and other things. So as the baseline risk increases, it makes sense to kind of intensify medical therapy, even if it is done for prevention. I'm not going to go through these, just know that there is these proposals, which you can read here in this paper, about staging and what to do with respect to therapies. And you can see as you go up from stage 0 to stage 3, then you can have, the slide gets busier because it gets more complicated medical therapy that we can utilize. So where does CT characterization, whether it's calcium score or atheroma phenotyping, fall within the realm of other risk markers? So one of them is polygenic risk score, which you've been hearing about. And if we were to compare ASCVD risk score with calcium score versus with polygenic risk score, polygenic risk score does not enhance the discrimination of MACE events in the future, as opposed to calcium score, which is a measure of atherosclerosis burden, can actually enhance our prediction. So this is just to say that I don't think the polygenic risk scores are going to be routinely utilized broadly when there is a significant availability of calcium scores. Where does it fall within the availability of biomarkers? So high sensitivity troponin has been linked with future risk of MACE. And you can see here in this graph where they followed patients across the strata of calcium score and high sensitivity troponin, you can see that both of them are independent of each other. I am not aware of a study that looked specifically at the discrimination, but this study looked at association and showed that they're all independent of each other. So there might be a room for incorporating biomarkers plus calcium score, specifically in those intermediate risk scores with calcium score, to re-risk stratify them into high risk versus low risk. One other thing that I wanted just to put a plug in here, this is the work we're presenting in ACC. It turns out that the social determinants of health can have a significant impact on risk in the future across the strata of calcium score. So this is in the x-axis, you can see calcium score 0 all the way to 400 plus, and then this is a measure of place-based social determinants of health, and as social determinants of health go up, the risk goes up of MACE, whether you look at it in relative terms, whether you look at it in absolute terms, and it goes across the board, even in patients who have calcium score of 0. Now, jumping into what are some of the work that we are doing here, and what is some of the work that would be needed to actually understand risk prediction a little better. This is work that we're doing looking at just using the same calcium score and deriving more information from the calcium score. So I showed you some work that looks at each individual component area density separately, but now you can actually look at, this is a reconstruction from a calcium score CT where you can look at the individual components of calcification, and then you can identify the centroids of them, and so you can understand the spatial distribution, but also the intensity distribution. And this here, at least in this study, looked at, we compared it with Agatston score, and you can see that there is better discrimination using ROC characteristics curves. Epicardial fat, epicardial adipose tissue is also a significant possible mediator of obesity relationship to cardiovascular disease. So you can see here that there's this you can actually extract it from from CT calcium scores. A little bit laborious, so we developed a machine learning program that can actually identify this automatically, and you can quantify this, and it actually is predictive. The intensity features of calcium score are predictive of MACE events, better than Agatston score and better than EAT volume, or the volume of the epicardial fat. And you can see here, this is freedom of MACE. It is nicely discriminated by epicardial adipose tissue omics or radiomics. Same thing you could do with these calcium scores that are cheap. You can look at liver fat, and you can quantify the amount of fat in the liver using these non-calcified, non-enhanced CTs. And now here we show that we also did, because it's somewhat laborious, we don't do it in clinical practice as much, but this is a way to actually identify this using AI and quantify the amount of fat in an automated fashion. And at least when we tested it in large multi-center cohorts of COVID, it is predictive of the severity of COVID and the outcomes, mortality in COVID. Now, you've heard a lot about ECG being predictive of everything under the sun. And you basically could, in theory, create some ECG risk scores that can be predictive of MACE events. So here, this is a work that we've done recently, where we actually use all the ECG stuff that we calculate and measure and take signals from and merge it with calcium score. And you can see, if you were to look at calcium score here, the AUC is 0.71. And as you add some features from the ECG, you can enhance discrimination. Now, we're getting into kind of information overload, because we have a lot of these risk prediction scores, and we need to integrate them somehow. But just to give you a perspective of what can also be done with CTA, this is work that we've done where we actually have paired CTA and OCT. This is intravascular, intracoronary optical coherence tomography, and we looked into plaque characteristics by OCT as relates to plaque characterization, thin cap, fibrous tissue, and monocyte activation, or macrophage availability, and microchannels. And we looked by CT, we looked at the pericoronary adipose tissue. And this is similar to the work that has been done in the past, looking at attenuation, but we went beyond attenuation, looking at the heterogeneity of the attenuation, looking at some of these radiomic features. And it looks like it's predictive. We can actually come up with a model that can be predictive of what we do find invasively on IVOCT. So it's predictive of TICFA to a certain degree with an AUC of 0.78. It's predictive of microchannels, and it's predictive of a combination of TICFA and microchannels. And for the interventionalists in the room, they understand that these are features that are highly associated with MACE events in the future. So there are actually commercial companies that do this now for a living. They do atherosclerosis phenotyping that were trained using AI, trained on histology that was derived primarily from carotid endarterectomy samples. And you can actually today, there is an FDA cleared version where you can estimate the amount of plaque, estimate the type of plaque using AI, beyond moving from the bins of Hounsfield units that we've talked about. Just because this is a multimodality imaging conference, I'm going to mention a couple of things. It turns out that we can actually also estimate risk or predict risk of MACE using echocardiograms. These are normal or seemingly normal echocardiograms that we picked up from a prospective cohort study called CRIC. These are patients who have chronic kidney disease that have these echocardiograms at baseline. And what we did is we identified the left ventricle, and we hypothesized that the left ventricle texture and the motion and the shape throughout systole and diastole throughout the cardiac cycle can be different between patients who have a high risk of MACE versus those who have low risk of MACE. And you can see here that across the board, patients who have lower risk of MACE have different texture, different composition, shape, and radiomics compared with the patients who have high risk. And as you go and follow these patients up, you can classify patients with a hazard ratio of 3, comparing them from high MACE versus low MACE. So you can, in theory, utilize, there's a lot of more work that is needed to synchronize, homogenize some of these studies, but there's, in theory, you can actually identify risk of MACE in the future just by looking at echocardiograms. So what is the future? The future is beyond AI. I think there is some emerging technologies that use in the coronary space, use coronary CT, of course, and atheroma phenotyping using AI, but there's also MR-based technologies that are still evolving. So T1 weighted imaging, There is a PET type of analysis looking at NAF, looking at dotatate. These are still evolving to understand disease activity and understand plaque characteristics. And you can apply the same technology both to the coronary space and the carotid space. A lot of it is being applied to the carotid space just because of the big vessel size. And actually, some of it is also applied to the aorta space, where you can look into the changes in FDG PET, for example, or FDG uptake, and in response to immune checkpoint inhibitors or some interventions that were given to patients. So this is where I think the future is. I think the future is combination, and we need to move from data to wisdom. This is what we propose, is basically combining some of these things that are available. Not all of them are available in the EHR, but a lot of them are available. If you see a patient in clinic, a lot of them have echoes, have ECGs, have x-rays, ECT, and sometimes the risk is discordant, sometimes it's concordant. The idea is to combine them all and perhaps also incorporate some language from the notes, what we talk about. Of course, I'm not going to be, I'm not going to belabor environment, but I think environment is also important. And kind of building this, I think this is really the future. It's risk prediction tool that can help us guide precision intervention, personalized intervention, not only based on the baseline risk, but also what is driving that risk. So inflammation versus fibrosis versus blood pressure, and also understanding type 1 versus type 2 myocardial infarction. But beyond that, also looking at heart failure and atrial fibrillation. So in conclusions, I think personalized prevention accounts for patient's unique profile, both from a characterization, but also from a likelihood of disease progression. Multimodality imaging can help identify patients who are at risk. I think we're still early in the personalized prevention. I think we're still depending on the stages. We're still depending on the risk related outcome. For example, we still prescribe colchicine in patients who have high risk versus low risk, but we don't really delve down into the drivers of atherosclerosis. So is it possible, for example, looking at pericoronary adipose tissue as an inflammatory marker and identify patients who may derive the best benefit from anti-inflammatory therapy versus those who have prothrombotic risk and so on and so forth. And I think advanced analysis, of course, AI is going to hopefully take over at some point, but I think advanced analysis of multimodality images can help us identify risk better, but also understand the benefit of personalized interventions. Thank you.
Least where you showed individuals who have atherosclerosis, be it calcified, CTA, there is tremendous heterogeneity, and we as cardiology tend to, again, as you pointed out, lump everything rather than split. Do you think that in the next few years, where a lot of work from you and others have, of course, one is logistics and number of lesions, their densities, diffusivity, and a lot of those things, how can we potentially, within our system, do you think that we may be ready in the next couple of years to have some of them? That's number one. Number two, and then again, the issue is how can we get the non-contrast CT to become a one-stop shop, which is beyond atherosclerosis, for more heart failure risk prediction, which is now clearly shown that segmentation allows better prediction than the BNPs, and for the stroke and for the fatty liver, and eventually with AI, potentially the pericoronary inflammation that can give us even more. So give us your thoughts on where the future could be in reality in the next couple of years with us here.
Yeah. So I think, you're talking about two problems. One is a multi-domain, basically, utilization of non-contrasted CTs, contrast CTs and stuff like that to predict, but also to predict multi-class, right? So predict, in addition to predicting MACE, but we can predict heart failure and predict AFib and so on and so forth. And I think the field is moving rapidly, actually, because now there are technologies that allows you to predict risk. that are, some of them are even if, 510K FDA cleared, that allows you to actually identify risk of heart failure, identify risk of AFib, and so on and so forth. I personally think that a lot of these will be driven by the availability of therapies, right? Nobody has been talking about heart failure prediction until now when we started to have SGLT2 inhibitors, although we've had ACE inhibitors, right? But nobody was excited about that. So I think there is a role for, once therapies are designed and therapies has been shown to reduce risk, they can drive and fuel innovation in this space. So I think, with the availability of SGLT2, GLP-1 receptor agonists, which have also been shown to reduce risk of AFib, reduce risk of heart failure, of course, and renal disease, these things can fuel the innovation in this space. I think from a health system standpoint, there is, we are on the cusp of doing transformation, I think. I think there is availability of data, richness of the data, also the availability of the raw data with the accessibility, with the infrastructure that you built. I think there is a way to actually move this rapidly, at least within our health system, to quantify calcification, for example, on non-calcified, on non-contrasted CT, to quantify heart failure risk from a calcium score, and so on and so forth.
So, Sadir, that was really very nice, comprehensive, and thought-provoking as to what could we use with all this technology, more and more refined every day. Question to you regarding, are there any data already? I know people are looking at it, I'm just not familiar with it. As to the advantage of having a atherosclerosis burden quantitation by CTA from a prognostic point of view compared to a calcium score.
Yeah.
Because, I see the calcium score as the iceberg, if you will, that you see, and it tells you about most likely the burden of soft plaques and burden of disease ultimately, right? And a corollary to that question is, since calcium scoring probably is not as informative in the younger population, where would you see somebody with high lipid burden? Do you see any role for a CTA?
Yeah. So thank you. I think these are important questions, and I think and Dr. Nasser wants to answer, sounds like. But I think when you talk about populations in general, right? When you talk about discrimination, right? Given the fact that calcium score is so powerful, the incremental added benefit of a CTA in a population is going to be very minimal, right? I think there are multiple studies that show that this, if you were to think about C index or area under the curve, it's not going to be significantly different. But I do think that in certain populations where, for example, you mentioned the young, right? You mentioned there are people who potentially have FH, familial hypercholesterolemia, or patients who have an inflammatory disease, right? Lupus, rheumatoid arthritis. There might be a role because basically what it does, that reflection of the ratio of the calcified versus non-calcified may not be equivalent to what we see in the general population. So it may be reflective. You can identify atherosclerosis a little bit earlier, a little differently, and you can target therapies a little differently. I don't think that is going to overtake the world as a first line because of the partly logistics, part the cost, part the radiation. There's a lot of different issues, and that incremental benefit is extremely minimal to suggest that we use this as a first line in everybody. But I think in select populations, it might be reasonable. I don't know. Dr. Nasser is more in tune with the.
I think so. I agree with your answer, and you mentioned logistics, cost, and you're basically alluding to value. And a big part of the value is what I would say is driven by impact. So the question really is is CTA a better modality for atherosclerosis imaging? Absolutely. Does it add for risk prediction on calcium score? The question is it by an inch or a mile? And if you look at through the spectrum, be it ruling out obstructive disease, ACS, even in symptomatic populations, if you have an absence of disease on a non-contrast, really there has been no data that has shown any incremental value. Even in the famous Scott Hart study, they literally have to twist themselves into multiple bends, and they couldn't show added value on top of a calcium score, even in that high-risk population. Now, The question is, what happens in a primary prevention? The answer is out. There are literally 3 studies, and one is Miami Heart Study, which we will have some data. I can tell you that out of 2,500 patients, only 50 patients had exclusively non-calcified plaque in one segment, literally a street. The second study is happening. We just finished up 200 patients in a very high-risk young population in Pakistan, CT and the calcium score, and what I'm hearing is that we are not seeing anything different. So my guess is that yes, for understanding biology, therapeutic changes, the CTA will really be the tool. However, if you're talking about population health and implications, I just don't see that adding anything meaningful. But of course, we need all the studies in inflammatory conditions. There is studies happening in FH, which even in the genetically confirmed FH young population, 20 plus years of follow-up, if you have a calcium score of 0, your risk is literally a flat line. So I think so that we may move in one direction then and eventually come back to the median where we'll say, at least for risk, understanding this should suffice, and then you refine it further.
Yeah. And I think one thing you mentioned is that the calcification is the tip of the iceberg, which I think is a good assessment. But I would say that the CT that we acquire, we have not milked the data. We have milked also the tip of the iceberg from the data, right? Because on the non-contrast CT, right? So the same CT, we're only reporting, we're doing a whole CT and we're reporting one number, right? But hopefully I convinced you that there is a lot more information that can be captured from this that can actually also refine risk better, which we could, in theory, we could probably even get better information compared with the contrast CT, because that contrast CT is confounded by the timing of contrast, the type of contrast, the concentration of the contrast, while the CT calcium score is a little bit more standardized. Yeah. So there is, pericoronary adipose tissue can be identified on calcium score, liver fat, like I mentioned, epicardial fat, even the size of the aorta, pulmonary artery, all of that is all risk that can be identified and drive multi-class kind of classifications of disease.